And the floor is now open for discussion, and by this I would like to invite our guest speakers to be on the podium. Any questions, please?
Good morning. Thank you for the presentations. I would like to ask if anyone has any experience with using SESTA maybe to look at this multi-drug resistance in breast cancer. It seems that it gets mentioned a lot, that it's fast washout and so on. But what is the practical kind of relevance of this? Can we use SESTA maybe, or has it been used to look at this aspect of the cancer behavior? Thank you.
Yeah, it's an interesting question. I think the challenge is that there was some very early data where people were looking at immediate post images and then 3-hour delayed images. And they certainly were able to calculate that there was a faster washout for multi-drug resistant tumors than tumors that were not multi-drug resistant. The problem primarily has been, I think, a protocol-based problem, that there's not a well-defined technique. So for example, are you drawing a region of interest around the tumor and then a region of interest adjacent to the tumor? Or are you drawing a region of interest around the tumor and a correlating spot in the contralateral breast? How are you getting these calculations of washout? And I think in the literature that I've reviewed, that seems to be the primary challenge. A very intriguing paper that I think I'd encourage you to read is Dr. David Mankoff did a great paper, and the technique that he employed was the contralateral region technique. And his data seemed to be much more correlative than other data. I don't personally have any experience with it, but I think that's been the challenge, is that some of the early people did it, reported it, and then other people tried to emulate it, and they didn't get quite the same results. But it may be more technique driven than anything.
Second question, there is this new LymphoSeek radiopharmaceutical, which has been approved only a few days ago for imaging mannose receptors. Any comments about the usefulness of that, maybe in practice?
Actually, would you just again your question?
There is a radiopharmaceutical which has been approved called LymphoSeek, which is tilmanocept, technetium labeled tilmanocept by the FDA. So it is for localizing of lymph node involvement, which is, a step forward in maybe sentinel node or lymph node evaluation of tumors.
Yeah,
but
I think maybe you meant antibodies.
No. It's just a compound which is similar to mannose, which is a glucose. a sugar. Sorry, and this has been released for imaging lymph nodes in breast cancer. Anyway, it's only few days. I read it over the internet.
We will look at it.
Maybe next year when we meet again. Thank you.
Thank you, Dr. Issa. Any other question? So I think by this,
yes, please. My question is combined to Dr. Hannah and Dr. Keeper, since we have both, aspects of radiology and nuclear medicine over here. In the situation where we have a patient with a positive family history of breast cancer, or a patient with breast implants, and a sort of equivocal or probably negative mammogram, what would be the preferred, way to go? MR, or first to do scintigraphy, mammoscintigraphy? and then from there proceed to probably MR or biopsy? I mean, I would like to hear both points of view.
So the patient with the positive family history depends on her age. So she's above 40 and she
Yes,
did mammogram
above
and it was negative.
Negative or equivocal, I mean.
Okay, and positive family history based on what? Does she have a BRCA1 or BRCA2 genes? How strong is the family history?
Let's suppose that this is a strong positive family history.
Then she should do MRI. She should do, and the recommendation now is, since we are doing the mammogram annually, the suggestion now is that she do the mammogram and then after 6 months she do the MRI. So she will be covered for 6 months by mammogram and then another 6 months by MRI. So she will do each modality every year, but one between the other every 6 months. It will be like that. And in case of a breast implant, we prefer not to do mammography because we don't want to rupture the implant. That's why we prefer to do the MRI. And I think with the Sinti, they will compress the breast.
No.
There is no breast compression. Then it's your field. Then you have to answer that. To us, we prefer MRI than mammography. We don't do mammography for breast implants.
I mean, okay, the question is...
she's a breast implant with a suspicion of mass, right?
Yes.
We will do MRI, not mammogram.
Okay, suppose that she had an ultrasound. Now, my question is, this is a patient who is having questionable mass.
Questionable mass by palpation.
By palpation, let's suppose that she did ultrasound or wherever. The question is, would you like to proceed immediately to MR or would you find a role of breast mammosyntigraphy in between?
Well, I am not aware of studies comparing MRI with cysto to see which is more specific.
There are studies that I'll cover afterward.
Okay, yeah. This will give you the answer. I'm not aware of it.
Yeah, so I think there are kind of two different thoughts. In the initial, you were saying somebody with no mammographic findings, only the family history is an indication. If it's that case, if the patient doesn't have findings on current imaging, but she has a strong family history, and you're trying to pick of all of these modalities which one to screen her with effectively. Yeah, I do believe that the breast MRI is more appropriate for that kind of screening, and the primary reason is that MRI doesn't involve radiation, right? So patient who's entirely asymptomatic, has no current evidence of disease, I think that patient is probably better screened with MRI. That said, we do find frequently, and this is true of the asymptomatic population on MRI, because MRI is primarily limited to vascularity imaging, you can get these patients who have a lot of enhancement all over the breast. And in those cases, we find that following them up with the symptomammography can be very helpful because the symptomammography doesn't have that same sensitivity to vascularity. Now, a patient who has a positive, some questionable finding on, so she has a strong family history and some questionable finding on current imaging, mammography or ultrasound, I would say worldwide that primarily goes to kind of the preference of the physician. Some physicians prefer the MRI and some physicians prefer the symptomammography, but I'm not sure that there's a strong correlation between which one's better.
Thank you very much. And I hope we can set, sort of clear protocols, that will incorporate both nuclear medicine and radiology technique, particularly at KCC, where we can find the role of symptomammography in the future. Thank you very much.
Thank you, Dr. Nafisa. Any other question?
Good morning. My question to Dr. Hannah. We all know that in cancer patients, the regular follow-up is by mammography, annual mammography. My question, can MRI replace that?
No, definitely MRI cannot replace that because MRI will miss the cases which will develop microcalcification. MRI will not pick up microcalcification. So, and the missing rate, in mammography, I said 5 to 15% will be missed, or in mammo, MRI can miss 5% of the cases. These are usually the low-grade carcinomas in which it doesn't enhance, and cases with microcalcifications. So the follow-up should be by mammography.
What about the 6-month MRI and then 6-month
Yeah.
mammography.
This is for screening for those who do not have a previous lesion. So that's why it depends on the question. It depends on the situation. If the lesion of that lady who had a breast cancer, the lesion was not picked up originally by mammography, yes, she should do follow-up by MRI as well. So it depends on the initial presentation of the patient.